Good morning, my eminent professors and colleagues. I am Ahmed Raafat, Demonestrator of Rheumatology and Rehabilitation, Cairo University. It's my honor and privilege to be presenting today at the Egyptian Society of Rheumatic Diseases meeting. I will be sharing two clinical cases within the Scleroderma spectrum that highlight the important differences in the clinical presentation, management, and decision making. I hope these cases will spark useful discussion and insights. Let us begin with the first case. A 55-year-old female patient, housewife, born and living in Giza, married with 3 offspring, with no history of pregnancy losses, with no special habits of medical importance. Her condition started in June 2024 with progressive skin tightness below both elbows, bilateral hand puffiness and arthritis in the small joints of the hands and knees, stitching chest pain, history of Raynaud's phenomena in both hands and feet for years. An immunofluorescence ANA was done and showed a positive 1/80 speckled pattern, and the patient was diagnosed as a case of a limited scleroderma. She received intramuscular betamethasone, oral prednisone 5 mg per day, and methotrexate 10 mg per week. 2 months later, the patient stopped all treatment after improvement. In June 2025, the patient suffered from recurrence of arthritis associated with significant weight loss. She received dexamethasone intramuscular for 3 days, followed by oral prednisone 5 mg per day, methotrexate, low-dose aspirin, and proton pump inhibitors. 2 weeks later, the patient suffered from severe headache. Her blood pressure was 210/100. Her CT brain was free and started tortamide 10 mg per day. 1 week later, she presented to our outpatient clinic with elevated kidney functions. Her creatinine was 4.5, urea 83. She had anuria, extensive oral candidiasis, and she was admitted for further evaluation. There was no history suggestive of other autoimmune manifestations, and her past and family history were irrelevant. Her blood pressure on admission was 150/90. Her heart rate was 112. She had limited range of motion in both shoulders, fish mouth appearance, and bilateral skin tightness up to both elbows. However, the review of other systems were normal. Her laboratory investigations showed a picture of normocytic normochromic anemia, thrombocytopenia, elevated kidney functions, elevated ESR and CRB, elevated serum uric acid, and elevated LDH. Her albumin creatinine ratio was 3.2 gram, and schistocytes in blood film were ordered. Her ANA by immunofluorescence was positive, 1/80 speckled. However, her anti-double-stranded DNA and extractable nuclear antigens were negative. Her echocardiography and pelvic abdominal ultrasound were normal. We considered this as a case of a scleroderma renal crisis, and she was managed through a collaborative approach with the nephrology department. Firstly, fluid restriction to 1 liter per day was applied, with improvement in the urine output noticed. Short-acting ACE inhibitors in the form of captopril was initiated, and calcium channel blockers was added for controlling her blood pressure with a target less than 130/80. A renal biopsy was taken. Topical antifungals, oral sodium bicarbonate, febuxostate, erythropoietin subcutaneous injections were added. However, persistent elevation in her kidney functions was noted over the next few days, with the creatinine reaching 9.8 and urea 164 10 days after admission. 10 days after admission, the patient started complaining of oliguria, generalized anasarca. Her captopril dose was reduced to 50 mg every 8 hours, and IV loop diuretics was added. However, no improvement in the congestion or oliguria was observed with persistently elevated creatinine. So, hemodialysis sessions and ultrafiltration were started. with adjusting the dose of the ACE inhibitors. 1 week after the regular hemodialysis sessions, we received the results of the renal biopsy, which showed a picture that is compatible of an active TMA on top of chronic one, with marked patchy tubular injuries. The arteries and the arterioles showed moderate to marked mucoid intimal thickening, with 2 arterioles showing fragmented extravasated RBCs and few arterioles showing onion skin appearance. Her schistocytes in blood film were 15%. As we can see, the patient had purely vascular affection in her renal biopsy, while the granulari showed ischemic changes and bloodless pattern. Also, the interlobular arteries exhibited the onion skin appearance, which is a key diagnostic feature of a scleroderma renal crisis on renal biopsy. A decision to start the plasmapheresis sessions was made. The patient received a total of 12 hemodialysis sessions and 5 sessions of plasmapheresis. Improvement of kidney functions was observed over the next 2 weeks, with the last creatinine 3.9 and urea 65. Improvement of anasarca, urine output, and the normalization of the blood pressure was also observed. To sum up our case, we have a 55 years old female patient, and on case of limited scleroderma, presenting to us with elevated blood pressure, elevated kidney functions, anuria, anemia, thrombocytopenia. Her renal biopsy revealed the typical histological picture of scleroderma renal crisis. She received ACE inhibitors, calcium channel blockers, and fluid restriction was applied, which was followed by hemodialysis and ultrafiltration, as well as plasmapheresis sessions with improvement. The patient was discharged on captopril, nifedipine, doxazosine, diuretics, oral sodium bicarbonate, iron tablets, and to follow up in the nephrology outpatient clinic for the decision of continuing the hemodialysis. Her labs on discharge were as follows. Now let's move on to our second case. We have a 35 years old female patient, housewife, owner living in Sohag, married with 2 offsprings, with a history of 2 abortions in the first trimester. She was a passive smoker. Her condition started in December 2024 with progressive skin tightness proximal to both elbows and knees, bilateral hand and feet puffiness, dyspnea on mild exertion, and of the phenomenon with pitting scars on both index fingers, fixed color changes in left index finger, dysphagia for both solids and liquids. An ANA by immunofluorescence was negative, and she was diagnosed as a case of a diffuse scleroderma. She received betamethasone intramuscular twice, azathioprine 100 mg, which was titrated to 200 mg per day, oral prednisone 20 mg per day, low dose aspirin. 1 month later, mycophenolate mofetil and calcium channel blocker were added, in addition to increasing the prednisone dose to 40 mg per day without improvement. On March 2025, the patient presented to our outpatient clinic with fixed chiral changes on her left index finger. We added phosphodiesterase inhibitors and started tapering the oral steroids to 30 mg per day. It should be noted that her CBC and kidney functions were normal during this visit. On April 2025, 1 month later, the patient started complaining of persistent vomiting and cough, whitish sputum, elevated serum creatinine, anemia, and thrombocytopenia, and she was admitted for further evaluation. There was also no history suggestive of other autoimmune manifestations, and again, her past and family history were irrelevant. Her blood pressure was 160/90, her heart rate was 112, and the patient was slightly tachypneic on admission. She had skin tightness on both upper limbs and lower limbs, proximal to elbows and knees, with pitting ulcer on both index fingers, and review of other system was also normal. Her laboratory investigations showed a picture of normocytic normochromic anemia, as well as thrombocytopenia, reticulocytosis, negative direct Coombs test, normal schistocytes, elevated LDH, elevated serum creatinine with normal urea, hypokalemia, hypomagnesemia, and hyperphosphatemia, which raised the suspicion of a pre-renal element. Her albumin creatinine ratio was 0.6 gram. The patient had elevated procalcitonin. Her ANA, anti-double-stranded DNA, ANCA were negative, while the extractable nuclear antigens were positive for anti-U1-RMB. Regarding the imaging done, her echo was normal with no evidence of pulmonary hypertension. Her HRCT showed a picture of bilateral upper lobes, subpleural ground glass opacities with 3 in bud appearance, as well as bronchiectatic changes. Her pelvic abdominal ultrasound showed mild splenomegaly. Again, a multidisciplinary approach and close coordination with the nephrology department was applied in managing this case. The patient was also placed on fluid restriction. However, the patient started hydrocortisone 50 mg ampoule every 12 hours, as the patient was on oral prednisone 30 mg with decreased oral intake and persistent vomiting. A long-acting ACE inhibitor was started in the form of ramipril with a target blood pressure less than 130/80. A renal biopsy was taken and IV antiemetics were started. On her 4th and 5th day of admission, the patient developed hypotension, so we stopped the phosphodiesterase inhibitors. Also, the patient started complaining of progressive creatinine rise and low IVC diameter, so the decision was made to stop the ACE inhibitors and increase the fluid intake with a targeted positive fluid balance upon the nephrology recommendations, as there was a suspicion this could be a renal insult with the introduction of the ACE inhibitors. On the 7th day of admission, calcium channel blockers were added for blood pressure control, and chest consultation revealed a picture of early interstitial lung disease on her HRCT. Between the 7th and the 14th day of admission, her creatinine level were stable and urine output was maintained. However, on her 14th day of admission, progressive rise in creatinine was observed with refractory elevated blood pressure, more than 150/90. The patient started complaining of oliguria, hypovolemia, persistent vomiting 4 times per day, and finally, generalized tonic-clonic convulsions developed, for which the patient was admitted in the ICU. On her first day in the ICU, the convulsions were refractory on phenytoin. The patient experienced 2 attacks of melena with thrombocytopenia 41 and significant hemoglobin drop. On her 2nd day in the ICU, the patient received IV methylprednisolone 500 mg upon nephrology recommendations for the sake of the severe thrombocytopenia and hemoglobin drop, and she started her first session of hemodialysis due to anuria, creatinine rise, and congestion. We received the results of the renal biopsy on her 2nd day of admission in the ICU, which showed a picture of active thrombotic microangiopathy, mainly vascular, with secondary fibrosegmental glomerulosclerosis. Unlike the first case, the renal biopsy here didn't show the typical histological features of scleroderma renal crisis, as it showed mixed glomerular and vascular affection. The glomerular affection was in form of segmental sclerosis, and the vascular affection was in form of moderate mucoid intimal changes, as well as some arterioles showing fibrinoid necrosis, fragmented RBCs, and thrombus formation. On her 7th day of ICU admission, plasmapheresis sessions were started in alternation with the hemodialysis. However, on her 9th day, the conscious level dropped, and brain imaging was done, which showed a picture of old ischemic stroke, as well as sinus thrombosis and Brest syndrome. Unfortunately, on the 12th day of post-admission, the patient suffered from severe hemoptysis. She was intubated and sadly arrested. So to conclude our 2nd case, we have a 35-year-old female patient, and on case of diffuse scleroderma, presenting to us with persistent vomiting, anemia, symptomatic thrombocytopenia, elevated serum creatinine, hypokalemia, elevated blood pressure, generalized tonic-clonic convulsions, sinus thrombosis, and Brest syndrome. A renal biopsy revealed the atypical picture of scleroderma renal crisis, mixed glomerular and vascular affection. ACE inhibitors, IV hydrocortisone, IV methylprednisolone and IV fluids were given. Hemodialysis in alternation with plasmapheresis were started. However, the patient suffered from disturbed conscious level, hemoptysis, and cardiac arrest. To sum up our two cases, we have two cases within the scleroderma spectrum. Both cases received high-dose daily corticosteroids before the onset. Both cases presented with elevated kidney functions, elevated blood pressure, anemia, and thrombocytopenia. Case A presented with anuria and extensive oral candidiasis, while case B presented with persistent vomiting and hypokalemia. The first case was a typical scleroderma renal crisis, while the second case was considered a part of a scleroderma thrombotic microangiopathy association in the light of the absence of an antiphospholipid profile, ADAMT13 level testing, which could exclude other possible etiologies. Both cases received fluid restriction, hemodialysis sessions in alternation with plasmapheresis. However, the primary distinction in the management of the two cases lies in the fact that case B had stopped the long-acting ACE inhibitors and received intravenous hydrocortisone and methylprednisolone prior to the initiation of the hemodialysis. Thank you.
معلش يا احمد، انا هسال بس سؤالين صغننين كده قبل ما نبتدي الدسكشن. انت وانت بتتكلم في الاول بتقول ان العيانه خدت 40 مللي جرام ستيرويدز without improvement. without improvement الايه؟
الفيكس كولر تشينجز والهاند اوفنس هي دي كانت المشكله الرئيسيه بالنسبه لي.
طيب هو واحده في سكيلوديرما الحاله دي ده كان بره، لان احنا ما فيش حد في السكيلوديرما بيدي يعني ما بديش انا عشان الجنجرين ولا عشان ده، وخصوصا عيانه بقى عندها كل الريسك فاكتورز ان هي يجي لها سكيلوديرما كرايسيس. لما دخلنا بقى تاني في الاي سي يو احنا اللي ادينا برضه
ده كان الكواليتي كوميونيكيشنز هم كان عشان السيفير ثرومبوسايتوبينيا كان شايفين ممكن
عشان انا حاسه ان في حاجات كتير قوي اتعملت عشان نوصل للبروجنوزس اللي هو. انا اسف